All right. Well, good afternoon, everybody, or good morning, depending where you are. And welcome to the 118th episode of the Crisis Jam. I'm Lindsay Browning. I am the Director of Medicaid Programming at the National Association of Medicaid Directors and one of the periodic guest hosts who pop in and had the honor to lead and facilitate today's conversation. We're really going to dig in and focus on the issue of mental health and police. We know this has been an area of active conversation in our community, in the mental health community, and we're really excited to have a featured presentation from Ron Bruno today to share with us. Next slide. So as always, I'd like to start off with a couple of updates and reminders, and hopefully folks have seen this before, but we continue to have a growing number of organizations involved in the group, and some of our highest areas of participation, our most viewed Crisis Jam episodes are here on the right. You can see that Youth Special Edition episode continues to exceed all the other areas, all the other previous viewership. And so if you haven't checked that out, would encourage you to go back and look at the recording there. Next slide. If you're having trouble with the calendar appointment, you can go to the Crisis Jam website and download the iCalendar file. So make sure you do that so you don't miss any of the weekly Crisis Jam episodes. Also, if you go to talk.crisisnow.com, you can get all of the recordings and materials and information from these weekly conversations. So bookmark that page, make sure you have that link handy. Next slide. You can see on the page some of the recent highlights, including a great conversation from last week around the Anti-Stigma Grand Challenge. So be sure to check that out. So I want to hit on a couple of news items from the week, as we always like to do. The first is an article that Ron Manderscheid wrote. I know many folks here, including myself, know Ron well. Really talking about some of the startling findings in the youth behavior survey that recently came out from the CDC, and emphasizing just the immensity of the crisis and the urgency facing teen and youth mental health. So that link's in the chat and would encourage you to check that out. Also, in the vein of talking about law enforcement and mental health, we wanted to remind folks about this article about the federal agencies convening both law enforcement and behavioral health leaders to discuss the shared opportunity of 988. And that was a convening led by or brought together by CSG a while back, but check out that news story as well. And then finally, you can use this QR code on your screen to check out a resource from NACO, the National Association of Counties, and NACBID, the County Behavioral Health and Developmental Disability Directors, around county funding opportunities to support that crisis response system. So check that out as well. Next slide. And then finally, and I think maybe the most challenging and sobering article that we wanted to share this week is just a story from the New York Times, really about the ongoing tragedy of police response to individuals experiencing mental health crisis, and of course the worst outcome of that involving resulting in death of the individual experiencing the crisis. So I think really underscoring the importance of the conversation we're having today, and the urgency of what we're facing as a country and as communities. Next slide. And this is our quote of the day. And in fact, instead of a quote, we're going to play a video from the chief of police in San Diego County, where they have been actively working on alternatives to police response and having community crisis teams respond. So we're going to play this short clip for you all.
Last year alone, San Diego County law enforcement responded to 38,380 calls for service for mental health related concerns. That's an average of 105 calls for service per day. While the men and women of law enforcement do a tremendous job every day evaluating these calls to bring help to those in need, we realize not all the calls require a law enforcement officer. Our partnership with the county's mobile crisis response team has allowed us to free up valuable law enforcement resources to focus on other areas of public safety.
To highlight one.
And I know that's an area of work that RI and the team here is looking at how we can continue to feature. So really some good effort going on in San Diego County. So without further ado, I am pleased to turn to our featured presentation today. Ron Bruno, who's the Chief Executive Officer of Crisis Response Programs and Training Incorporated, is here to join us to talk about this subject of mental health not coming in a police car. And he did a crisis talk a while back with Stephanie Hepburn, and I believe that article was one of the most frequently read articles in the history of the Crisis Jam. So really pleased to welcome Ron back to share with us, and then we'll turn to some discussion. So Ron, take it away.
Thank you, Lindsay. So anytime that I talk about crisis response system reform, I always start with this slide. And the reason is because too many times when we do talk about reforming our crisis response system, we always look at it from our own lens. We look at it on how does the system work for us? Those of us that are providing services, those of us that are trying to get help to the individual. But we really need to look at it through the lens of the individuals that are utilizing the systems, the individuals that are experiencing crises. And this slide really kind of demonstrates that, because over on one side, you see the person standing on top of the mountain, just kind of looking at that valley below. And that is kind of what crisis is like. It's very lonely. It's very scary, and it can be very dark. And then on the other side, you see the person standing about to enter a maze. Because unfortunately, that's kind of what crisis response systems look like. It's a maze. Where do you get help? How do you get help? Do you have to wait before you can get an appointment? Do you need some medications? If so, who are you going to see for those medications? Things are getting better, but still, when we talk about crisis system reform, we really do need to always think about the end user, the individual that needs the help, and how the system is going to best fit their needs. Next slide, please. So what we want to do is we kind of want to walk through the best practices in crisis response. You'll see that there's a blue line going down the center of the page. That blue line realistically divides two separate and distinct systems. Next slide. On one side, we have the gentleman in the blue. He represents 911, or also the criminal justice system, of course. Over on the other side, we do have the lady in the gray shirt. She represents crisis services, or a crisis line such as 988. Now, there's a lot of talk about integrating these two systems. I don't recommend integrating the two systems. What I do recommend is to be able to connect the systems only at those times that it is appropriate to do so. Next slide. So for example, when a call comes in to 911, we need to train all of our call takers throughout the country and actually worldwide how to triage that call. Begin the de-escalation process. Well, first off, recognize that they're dealing with a mental health issue. Next is start the de-escalation process, then be able to triage the call and make a determination. Do we need law enforcement to respond? Is there an actual emergency that law enforcement and armed officers should go out and handle? If not, we should have policies in place that are going to do a warm handoff from that to the crisis services. And then the crisis services can do a secondary triage. Anytime that they feel that there is a safety issue, they can always do a warm handoff back to 911 and then send out law enforcement services for the safety aspects of it. But this realistically begins the process of diverting individuals from the criminal justice system. It starts to put people in the hands of the behavioral health care system right up front. Now, we do know that the majority of calls that go into a 911 emergency center do not require a law enforcement response. And we also know that the majority of calls that go into a crisis line are resolved at that level without ever having to send anybody out of the community. I mean, we're seeing numbers between 80, 90, up to 95% out of these centers that the calls are resolved, again, without sending anybody out into the community. Another benefit of this system, next slide, please, is that we can also tap in a warm line. Warm lines are generally staffed by certified peer specialists. And the difference between the crisis line and the warm line is that the warm line is basically an empathetic ear to talk with the individual. It hopefully is somebody that has the lived experience that can kind of share what they've experienced when they're into a crisis situation. You know, you ask any 911 call taker, or you ask any law enforcement officer, is there somebody in your community that is constantly calling 911 and law enforcement is going out, but there is real no emergency or situation that 911 or the law enforcement officer can deal with? Well, those kind of calls are the perfect call to get tied into a warm line, because what happens is that the person on the warm line can actually build the rapport and tell the individual, hey, next time that you are experiencing this, next time you're feeling this, next time you have that anxiety over that situation, you know, as long as you're safe, instead of contacting 911, please contact the crisis line and ask to speak to one of us on the warm line. And we'll be glad to walk you through it. And let's see if there's other ways that we can deal with these situations. I have seen individuals that are constantly involved in calling 911 be able to be diverted from that system and get handled by the warm line services. Next slide, please. Now, over on the 911 side, of course, we already have assets that we can dispatch out. We have EMS and we also have law enforcement to send out. However, what we really need to be looking at is how do we not utilize those assets except when it is a true emergency? Next slide. And that's why we need to make sure that every community is developing non-law enforcement crisis response teams. Now, these teams are made up of various disciplines. You can see teams that are made up of a clinician and a certified peer specialist. You can see these teams made up of a crisis worker and a medical staff, such as an RN or a paramedic or an EMT that would go out and deal with the situation. You may find teams that actually combine those three, where you do have the medical, you do have the clinical, and you also have a certified peer specialist going out and dealing with the situation. Next slide, please. And just as we made that connection between 911 and the crisis line, we need to make that same connection here at this level. We need to make sure that we are training a cadre of law enforcement patrol officers to learn how to respond to crisis situations. And we need to train them on how to work with the non-law enforcement crisis response teams. And at the same sense, we need to train the non-law enforcement crisis response team members on how to work with those specially trained patrol officers, crisis responding patrol officers. Because we hear a lot about embedded co-response, and that is where you take a law enforcement officer and you take a clinician, you put them in the car and they co-respond out to crisis situations. But with that kind of model, and you know, if your community's doing that model, it works, great. But generally, the greatest majority of communities cannot support having that model as well as building non-law enforcement crisis response teams. Or the other problem that we see with that kind of a model is where the larger departments, you know, one or two within a county, can actually support that model, but there's not enough funds for every other community to be able to have that model. So they may not have the assets of being able to send out non-law enforcement services. But getting back to this, if we do train the non-law enforcement crisis responders and the specially trained law enforcement officers on how to work with each other, we actually do have the same results as an embedded team, because they can both show up on scene together before making contact, share information, and then go out and be able to decide how they're going to approach the situation and then deal with the situation. Another benefit of this model, doing it this way, is that the majority of times when law enforcement does respond out with these teams, they don't have to stay on scene. Many times they can be released and go back out while the non-law enforcement crisis responders can stay on scene for half hour, hour and a half, whatever it takes. And we're not just having a law enforcement officer stand around. Next slide, please. Now, as you look at this and you think about SAMHSA, and what they're promoting in crisis response, it's realistically somebody to talk to, and we've done that on that first level. Somebody to respond, and we've done that on the second level. Now what we need to do is make sure that we have the assets for the third level, which is someplace to go just in case somebody needs help. And that's where we already have emergency rooms. The question is, are the emergency rooms the appropriate place to actually take a person in crisis? And I would challenge to say, probably not necessarily the best place. Now, the reason for that is it is the model. Think about it. Emergency rooms are realistically set up to be able to bring somebody in, stabilize, triage, stabilize, and then either discharge them or hand them off to a specialist. That's the model. If you look at emergency rooms, the environment is very busy. It's bright. It's active. You have people that are yelling. You have people that are talking. You have people that are laughing. And a person in crisis, it's really difficult to have that kind of an environment. So instead of utilizing emergency rooms, we need to also make sure that we are utilizing other assets, such as a dedicated receiving center. Next slide, please. Now, dedicated receiving centers or crisis centers are basically built on the living room model, where it is handled at a slower pace. Most often when a person comes into an ER, they're asked for their insurance and get all that information up front. Sometimes they're made to undress before they will actually receive any type of help and put on a gown. But over at the receiving center, the crisis center, it's handled where generally when a person comes in, they're asked, when's the last time you had something to eat or drink? Can I get you something to eat or drink? The crisis is handled at the pace of the person who's experiencing the crisis, instead of being handled at the pace of the institution. So it brings things a lot calmer and relaxed. The other thing that's nice about this is that people are more apt to actually utilize crisis lines, and if they feel that they do need to talk to somebody in person, to go to the crisis center themselves to get the help, and never involve 911 or law enforcement services. When we talk about crisis response systems, we always do need to think about the individual that is utilizing those services. And when we talk about reform, we've got to make sure that we are developing, reforming crisis response systems that are the most compassionate, the most effective, and the least intrusive in the lives of individuals who experience crises. Next slide. So this is my contact information. I really enjoy and love talking about crisis response systems. Feel free to reach out to me if you have any questions on anything that we're covering. So thank you for this opportunity.
Ron, thank you so much for sharing. And before I turn to our roundtable, I just would love to ask you one quick follow-up question. I love this notion how you talked about the criminal justice system or the 911 system being connected but not integrated with 988 and the behavioral health crisis response system. And you talked a lot about the need for kind of co-training on both systems so folks know when to make that handoff. But I'm also curious, it feels like culture change in both systems is also needed so that there's the trust and the capability of making those handoffs as well. And anything you'd comment around, the culture change piece?
Yeah, absolutely. And it's hard to change. Change is very hard. I mean, I've been doing crisis reform assistance for many, many years. And even today, when I talk to some chiefs, they still have the misunderstanding that a person in crisis is a danger. So they have to send out law enforcement to make sure that even if mental health is going out, mental health services are going out, that they are safe. And we know that people in crises, the greatest majority are not violent. And that's where we need to make sure that we're doing that triaging and training, not only, but also training 988 or the crisis line personnel on how to do the triage and look for the safety aspects. But change is hard. When we talk about reforming these types of systems, it can go either way. It can start at the top and move its way down. Or the other way that it can happen, and I've seen it happen more often this way, is it starts with somebody that is, at the boots on the ground level, whether it's on the crisis side or whether it's on the criminal justice side, that they say we need to make these changes, and they start to build up support, and they start to move it up until the administrations of those two systems start to say, hey, that does sound like it would work.
Super helpful. Thank you. I want to turn to our roundtable discussion based on what Ron shared. So I'm going to turn to Dr. Don Kamen first, who's the director of the Institute for Police, Mental Health, and Community Collaboration, and then we'll go to Dr. Amy Watson. So Don?
Sure. Well, thanks for having me to be part of this important discussion, and thank you, Ron, for a very thoughtful, I think, and helpful presentation. I'm Don Kamen. I'm the director of the Institute for Police, Mental Health, and Community Collaboration, whose main mission is to develop crisis intervention team or CIT programs across New York. We also do related work within New York and other places. And I'm also the vice president of crisis response programs and training. I want to mention a few things that highlight the importance of the system transformation that we're talking about, specifically the adverse outcomes that can occur when police are the sole responders to individuals in emotional distress. Research shows that individuals with serious mental illness have disproportionate rates of arrest and incarceration. The other issue that I think is really worth noting in the context of this discussion are the tragic outcomes that can occur when individuals with mental illness interact with law enforcement. And we all know too many examples of situations where individuals have been seriously hurt and even killed because of that interaction. In fact, Lindsay just mentioned one in her introduction that recently happened in New Jersey. Sometimes it's the law enforcement officer that's the injured party, but usually it's the person with mental illness. The Washington Post has been tracking fatal police shootings across the nation since 2015, and the results show that over 20% of fatal police shootings involve someone with mental illness. So, these two problems, disproportionate incarceration and tragic outcomes, are why it's imperative that we keep working toward non-police responses to individuals in crisis. And the best way to prevent arrest and tragic outcomes is to only have police respond when needed, as Ron alluded to. When there is some element of dangerousness that needs a police response and or criminal activity that warrants a police response. So while we need to strive for non-police responses as much as possible, there will be times that we need police to respond. And some of the work I do is around training police in the context of developing CIT programs. And just real briefly, for those that don't know, CIT programs aim to transform crisis response systems to minimize the times that police officers are the first responders to individuals in emotional distress, which of course is very consistent with what we're really talking about today. In other words, if there's a mental health related crisis, we need to have a mental health response. And the second thing that CIT programs do is to ensure that when police are the first responders, that they have the knowledge, the skills, and the support to de-escalate situations and divert individuals from the criminal in juvenile justice systems when that's possible. And that's of course, the training part of CIT. So we need to keep training police, but training in the absence of system reform is not nearly as effective as training in the context of system reform. One other thing I want to briefly mention is that research shows that persons of color experienced increased uses of force in their interactions with law enforcement, and data show that individuals with mental illness have similar experiences. So persons of color with mental illness have both of these risk factors and are therefore especially susceptible to poor outcomes in interactions with police. And so that's just another reason why non-police responses are important. So I will yield my remaining time to my distinguished colleague.
Thank you so much, Don. Dr. Watson.
So, hi everyone, I'm Amy Watson. I'm a professor at University of Wisconsin-Milwaukee in the School of Social Welfare. I'm also president of the board of CRPT. And I really want to say I agree with everything that Ron presented as well as Don's comments. And I actually see a comment in the chat about there's an opinion on using co-responders as an opening attempt. So sort of as a first step towards moving towards more of a mental health response. And I think some of it has to do with how you think about co-responders. Law enforcement and mobile crisis teams always have the option of co-responding. If it's really important that there are partnerships so that when a situation requires it, you could have law enforcement call a mobile crisis team or a mobile crisis team ask for assistance from law enforcement. I think the problem with embedding the co-responder in law enforcement is just sort of a continuation of something that I've seen over the past couple of decades that I've been doing this work. As we became aware that we had an overrepresentation of people with mental illness involved in the criminal legal system. And so we started building programming around this. And what we ended up doing is building a larger mental health system within the criminal justice system than we had outside of the criminal justice system. So that in many places, the only way to get help quickly is to end up within the criminal justice system. And too many people are actually accessing services that way, as opposed to having that available without the criminal justice system involvement. So I think that's where the danger kind of comes in with moving towards embedding a co-responder with law enforcement, as opposed to developing some resources outside of the criminal justice system and partnering when it's appropriate, if there is a criminal concern or a significant safety risk. So that's kind of how I think about this. And what I wanted to also make a couple comments on is, as we think about really shifting response away from law enforcement when it's appropriate, we have to think about who should the responders be. And I see, different communities building teams made up of different types of professionals. Some teams are trying to be built with all licensed clinicians, which certainly there are situations that having a licensed clinician on scene is necessary or really helpful. Something that I see in my state is in many parts of the state, mobile crisis is it's one person that goes out. They will only go to secure settings, so either a school or an emergency room. And they're so under-resourced that they primarily go out when there's a question of whether someone needs an involuntary petition. But I think we want to think about crisis response more broadly so that people can access crisis support and stabilization in the community. So a broader kind of set of types of situations. And many of those situations don't require a licensed clinician, perhaps supervision of a team by a licensed clinician. So we really need to look at who should be responding, how we build these teams, and how we need to prepare them. And I have seen more communities start looking at bachelor's level crisis workers, certainly including recovery support specialists on these teams can be really critical. And there are some teams made completely of recovery support specialists and the peer workforce. I think we need to really kind of boil down kind of what skills that we need our responders to have, and really work towards identifying folks that are coming with the right orientation and help build those skills. And in order to really build our workforce capacity, I think we need to also consider removing some of the barriers to entering the field. So maybe not as many educational requirements, but building some training for folks that are well suited to the work, and perhaps some certifications and some professional pathways for community crisis responders. And, you know, I educate social work students, and I have for a long time. And social work education at the master's level doesn't necessarily require content on responding to crisis in the community. So I think there really is a need for us to look at what should that training be, and making sure that we're providing it to the people that we're moving into these roles. And again, I think we're starting to see communities do this to a certain extent by necessity, because we simply don't have enough master's level clinicians that want to work strange hours, particularly when they have more opportunities to even do virtual therapy and those types of things. So we need to be creative, but I think kind of that necessity is going to help us develop a more effective crisis response by really looking at getting, you know, a good workforce prepared and getting the right people in these roles. So I will end with those comments.
Thank you, Amy. I think really interesting and important point around, you know, that it's easier to access some of these services through the criminal justice system today than it is outside of it, and the vision and the work that we all need to do to make it easier to access mental health supports outside of that system, and building the workforce and capacity to achieve that vision. So really appreciate you sharing those thoughts, and thank you to Don and Ron as well for really sharing a great perspective about how we think about building the system. So I want to transfer us and move us along through our agenda to our standing updates, and just want to give some quick reminders before we move into our next segments here. The first is to encourage folks to go check out the SAMHSA 988 store and the 326 items that are available there to promote and raise awareness of the 988 crisis line. Also remind folks, if you're interested in getting a t-shirt, you can volunteer for the trivia hot seat. You can also volunteer a friend, and your friend can be voluntold to do the trivia hot seat. So would encourage you guys to connect with Karen if you're interested in doing that. Next slide. All right, so let's go ahead and move into our trivia hot seat. Before we, as we do that, Sue Ann O'Brien is in the hot seat today, and she's the president of Behavioral Health Link. So Sue Ann, you want to just quickly introduce yourself?
Sure. Hi, everybody, and thanks, Lindsay, for having me. I'm Sue Ann O'Brien. I'm the president of strategic development for Behavioral Health Link. I've been with the company about 3 years, and really in charge of some national expansion for the company, and doing lots of great things with a lot of wonderful partners on the ground.
Fantastic, and thanks for being willing to be in the hot seat today.
Sure.
In continuing with our theme around the intersection of law enforcement and behavioral health, here is our question. So as a little bit of background, we know there are approximately 18,000 federal, state, and local law enforcement agencies in the U.S. In 2019, the Roadrunners report compiled some responses from over 300 of these law enforcement agencies to questions about behavioral health involvement. And our trivia hot seat question today is about one of those findings from this survey. The question is, just for those 336 agencies that completed the survey, the total annual distance transporting individuals with serious mental illness was 11 times what? 11 times the distance from LA to New York City, 11 times the distance from Alaska to Puerto Rico, 11 times the distance around the Earth's equator, or 11 times the distance to the moon and back. And so we have a poll question up and would encourage folks to help Sue Ann out. And Sue Ann, you can look at the poll results, you can phone a friend, call out a friend on the Zoom, or both.
Okay. Well, I've read the Roadrunners report. It's been a few years. I don't remember this particular item. Let's see. I think I'm going to go for it.
Okay. Do you want to see the poll results real quick?
Sure.
Okay. You could disagree with the audience. Oh, it's pretty split. So you're gonna have to.
Oh wow, that's pretty close. Okay, so I was gonna say LA to New York City. So it looks like that's an even with number 3, the Earth's equator. I'm gonna stick with my initial gut and say A.
All right, so we can move forward and see the answer. The answer is to the moon and back. So without community-based mobile crisis teams, police, of course, are the default first responders. And it's estimated that over 20% of total police staff time is used responding to and transporting individuals in behavioral health crisis. So clearly quite a distance. So I don't know, is that surprising, Sue Ann?
That was surprising. I thought, do we know that distance? And who did that calculation in the crisis world? But yeah, I mean, it makes sense. I mean, everything that we're talking about today, the points that everybody else has made so far this morning have been incredible. And I think this is still an issue that we need to address. So surprising, but also, yeah, when you think about it, this is still one of those problems that need to be solved.
Yeah. And you still get your shirt. Don't worry. I got this question wrong too in our green room. So, so thank you, Sue Ann. Really appreciate it.
Yep. Bye-bye.
And we've got a bonus quote today that really hits on just the magnitude of this issue. So from that Roadrunners report, the quote is, 3 hours is the average time an officer waits at a medical facility until transfer of custody occurs. And 5 times longer is the average distance to a medical facility than to jail. So you can start to see from this quote, from the data we just looked at, why we have this challenge of law enforcement often incarcerating an individual, booking an individual rather than taking them to the emergency department because of the challenges, the inefficiency that creates for the police officer in doing their public safety job. Next slide. All right, so I'm going to turn to our next standing update, which is from SAMHSA. So John, take it away.
Thank you, Lindsay. Really happy to be here. I'm so excited about the sort of theme of this week with respect to building out non-law enforcement response to crisis situations. Lindsay, your last point about how long police law enforcement spends with individuals in hospital emergency departments. I know it really points to why there's so much importance on that handoff time. And I know that there are centers around the country that provide receiving and stabilization services that actually have been able to make it a very quick process for law enforcement personnel, and that's critically important that we build those systems of care so that it is an easy alternative for them to hand off somebody who will be better served with health first responses. Anyway, I got distracted by that for a minute, so I'll go on to my original comments, which were I think to appreciate Ron and his comments here, and also very much appreciated Amy and her talk about composition of crisis workforce. This is an area that we are very interested in at SAMHSA with respect to building pathways to the crisis workforce that are pathways outside of licensure per se. So really interested in that conversation, and I may very well reach out to Amy to further advance that conversation. I did want to flag a couple of things that people may not be aware of that very much in line with the theme of today. One is a findings report that came out from the Department of Justice with respect to the Louisville Police Department. This is a very troubling report, but probably not surprising to many folks on the call, that speaks specifically to discrimination against Black people and also discrimination against people with behavioral health disabilities. I would say that the sort of the positive aspect of this report is that there are a number of remediation steps that are recommended. And I do feel like this is an opportunity for us at the federal level to lean in with our federal partners at Justice to be able to support expansion of non-law enforcement responses to crisis situations. I also will, and I'll throw the report in the chat for those of you who are interested in taking a look at it. I will say that Department of Justice actually has a number of investigations underway in, I think, about 8 other cities around the country. And then wanted to also put it in the chat, just flag awareness for a report that came out from the Center for Policing Equity on mental health emergency response, which is again very much aligned with what we've been talking about today with respect to health first responses to crisis situations and building out mobile crisis response that does not include law enforcement. And then finally, I know that you'll get a little bit of a more specific update on the numbers, but just wanted to let folks know that the FY24 congressional justification is out, and I will throw that link to the 300 or 400 page document in the chat for those of you who would like to read it. But overall good news on the crisis front with respect to increased proposed funding for the 988 Suicide and Crisis Lifeline, as well as mobile crisis services, as well as increased set aside through the block grant, but you'll get more details momentarily. Back to you, Lindsay.
Thanks, John. And I think there's a plenty of nerdy folks on this call who would read the president's budget as some light bedtime reading. So appreciate that. All right, next slide. I want to turn now to Brian Hepburn for an Ash Pit update.
Thank you, Lindsay. And thank you for another excellent jam. David Covington and team, week in and week out, continue to do a great job. Also, thank you to SAMHSA for their continued leadership. Also, Ron Bruno, again, excellent presentation. And John, Ron is just super impressive with his continued leadership and insights. Wanted to let you know that across the states are working on issues, including crisis services. The movement continues as was expressed today, the goal is to use law enforcement when they're needed, rather than having them be the first responders to individuals with behavioral health issues. We want to make sure that the first responders to people with behavioral health problems are individuals with expertise in behavioral health. That allows for a better outcome and allows for the police to do the work that they are best prepared for. Also, states are working on workforce, and this has been addressed by several previous speakers. The states are highlighting that if we're able to effectively change the system, especially using crisis services, decrease the number of people going to emergency rooms, decrease the number of people going to jail, keep people in the community. By doing that, we change the workforce needed. And this is something that was brought up by Dr. Watson in her comments, and states agree. Let's change the system, make it more effective, and start including individuals who may not be licensed, but could be trained to do an effective and very efficient job. The other is to, as Dr. Watson brought up, emphasizing peers and the importance of peers throughout the system, and doing a better job of including peers. We know that the states are also very focused on the end of the COVID emergency and the impact that this will have on individuals who are recipients of Medicaid services. This is something that is of great concern. The flexibility during COVID that allowed many people to be eligible for Medicaid that won't continue beyond the emergency status, that's of concern. How do we make sure that those individuals with the greatest need for the services will continue to get those services? So that's something that states are working on with their Medicaid authorities, and we know that CMS is working on this nationally. It continues to be a major issue for the states. So with that, I will turn it back to Lindsay, and thank you for allowing us to participate.
Thanks, Brian, and really appreciate you raising the end of that continuous coverage requirement of Medicaid. For all our Medicaid colleagues on, this has been this is a huge undertaking and is a huge area of focus, and would encourage you all to stay plugged in, stay connected to what's happening on that front. All right, I want to turn it now to our federal update. So Joanna, can I turn it to you?
Absolutely. Thank you, Lindsay. So I know Sarah and I have been teasing the president's budget proposal for what feels like last month. We finally got it last week, as John mentioned. So we have some numbers to share with you. As a reminder, this is the president's proposal. So now the House and the Senate are going to work on their bills, hold hearings in their subcommittees, and determine what levels they'll be including in their budgets. So the biggest takeaways from our community is in the FY24 president's budget request are up here on the slide. Obviously, the biggest thing is the 988 Suicide and Crisis Lifeline and Behavioral Health Crisis Services line, which sets the funding at $836 million for Lifeline operations and crisis services. This funding is going to go towards specialized services for LGBTQ youth, for Spanish speakers as well, and then also towards local crisis call centers and a national media campaign. This is all intended to respond to the expected increase that SAMHSA foresees for 988 outreach in 2024, which SAMHSA is estimating to be around 9 million contacts. There's also going to be the community mental health block grant, which is funded at $1.7 billion with a 10% set aside, which is up from 5% in FY23 to be used on supporting crisis services. The CCBHCs are also funded at $553 million, which is $160 million more than last year. And then the Mobile Crisis Response Partnership Program was given an $80 million bump from FY23 levels to fund it at $100 million this year for FY24. So that's really exciting to see. It's great to see these investments from the administration. We do want to keep in mind that this year appropriations are going to be a little bit trickier. We are expecting to see some cuts on the House side, so we're going to be keeping an eye on everything over the next few months. But this is a really great first step, and we're really encouraged to see the prioritization of crisis services.
Thanks so much. All right, I'm going to shift us now to our state update. So Caitlin, can I turn it to you first?
Sure thing. Thanks so much, Lindsay. So we've seen lots of movement over the last week on several pieces of state legislation, but I just want to take a moment to highlight House Bill 2757 in Oregon, which would provide funding for 988 through a trust fund and includes a monthly telecom tax of 50 cents. This actually moved through the House Committee on Behavioral Health and Healthcare, recommended that the bill pass, and was referred to the Revenue Committee. So we'll continue watching that for a vote out of the Revenue Committee. Additionally, we've seen multiple states introduce, move, and pass bills related to including 988 on student ID bills. I know youth mental health is a huge topic that we talk about a lot on the Crisis Jam. So just want to highlight the work that Virginia, West Virginia, Iowa, Minnesota, and New York have undertaken this session. And I will pass it over to Stephanie for some more updates.
Thanks, Caitlin. I just wanted to touch on two more states. In South Carolina, the governor released his proposed budget. And although this is just a proposal at the moment, I wanted to take time to highlight South Carolina because folks on this call might remember last summer, South Carolina actually making national headlines, raising concerns about the lack of increased funding for their state's low 988 call center, which is located in Greenville. But things are looking brighter in this new proposed budget that was just released. If the legislature takes it up, as it's written, that would include $9.2 million in reoccurring funding to support the call center located in Greenville, and also to establish a second call center in the state to increase overall capacity. Additionally, you'll see it may be small, but you can see highlighted in yellow there, Rhode Island. So State Representative Mary Ann Shawcross Smith has reintroduced her 988 implementation bill from last year. This is a very comprehensive bill based on the model legislation and would include a 988 fee. And that bill number is H6121, and I will add a link to both these proposals in the chat. Thanks, Lindsay.
Great, thank you both. Appreciate those updates. Next slide. All right, we want to draw your all's attention to the latest Crisis Talk article. Stephanie Hepburn is not able to join us today, I believe, but I want to encourage everybody to check out this article that really highlights the incredible work of NFL player Doug Middleton in the wake of losing his best friend to suicide. Doug has really become a champion of mental health and increasing awareness and working to destigmatize mental health in the wake of losing his friend to suicide. We have a short clip to share from Doug talking on the recent podcast about this work as well. But again, would encourage you all to check out the article. So let's go ahead and move to the audio clip.
And what I had to learn is how to, really take, my physical health is just as important as my mental health. And so with that, if you have a broke ankle, you're not just going to, run back out there and play. And, as my friend started to suffer from depression, we treated it like it was just, like it was something different, like it was just something that you could just overcome, something that you could just push through. And so going into my second season, we lost my best friend, AJ, to suicide. And, from that moment in 2017, I just wanted to figure out a way that I could make sure that, other people did not suffer the same way that AJ did. I want to find a way that student athletes that experienced the same type of journey, had been through the same type of adversity that they experienced, that they were able to find ways to, connect to mental health resources.
So really, really powerful story on the Strong Talk podcast. So again, check that out. Check out the article. I want to turn now to Travis Atkinson from TBD Solutions to talk about a survey that they are fielding around behavioral health crisis stabilization centers. So Travis, I'm going to turn to you.
Thank you so much, Lindsay. Good afternoon to some. Good morning to others. TBD Solutions is conducting a national survey of behavioral health crisis stabilization centers to better understand the presence and function of those alternatives to emergency departments and psychiatric hospitalization. We know that crisis stabilization centers are referenced as a critical component of a functioning behavioral health crisis system by both SAMHSA's national guidelines for behavioral health crisis care and by the National Council for Mental Wellbeing's roadmap to the ideal crisis system. So if you're wondering who might be eligible to respond to such a survey, we're looking for 23-hour crisis stabilization units or 23-hour OBS units, psychiatric urgent care centers, comprehensive psych emergency programs, psychiatric emergency departments, empath units, living rooms, anything that's located in a facility that would offer urgent care and up to 23 and in some cases up to 72 hours. So you can see we've got a tiny URL right there, and it looks like Kristen popped that into the chat as well. So the survey will be open through March 31st, and those who participate in the survey will get early access to the results. Thank you.
Thank you, Travis. I think having data and insight about how we're situated, how this part of the delivery system is situated is so critical to inform all of our collective efforts and to inform policymakers. So really, really appreciate that. I want to remind folks about what's coming up soon here in the Crisis Jam. You can join us next week to hear from Becky Stoll about caring for the crisis carers. We know this is such a critical part of building a strong crisis system is supporting the individuals who are doing this work day in and day out. So really excited to hear from Becky next week. In addition, you can join us on March 29th to hear from Kim Sanders at Yukuru, and then Cosette and Ton Hall from Rakim on April 5th as well, really to hear about those community-based resources that are supporting but separate from law enforcement. So encourage you all to join that as well. Next slide. And then just again, always like to wrap up with a reminder about a Moving America Soul on Suicide. You can check out the official trailer for that. I know we'll drop the link in the chat. Episode 2 in particular, it focuses on a particular story around around a particular individual and kind of the experiences of communities of color and the deep disparities we know exist there. So I would encourage you all to check out that episode. And then we know episode 9, I think, is about to drop as well. Because I've managed to wrap us up a little bit early, I would love to invite Ron Bruno back for any closing thoughts as we draw to the close of this hour, really focusing on the intersection of law enforcement and the mental health system. So Ron, are there any closing thoughts you would like to leave the group with as we conclude today?
Yeah, I mean, the biggest thing is that it's something that we need to bring together the community to really look at. We can't do it alone. Law enforcement can't do it by themselves. Mental health services can't do it by themselves, and advocacy services cannot do it by themselves. We need to bring those 3 entities and all the resources in the community together to look at the crisis response system and then map it out, find the gaps, find what's working, and decide how do you want to reform your crisis response system. You know, it does take the support of all the entities working together.
Thank you, Ron. And I think from the Medicaid perspective, because that's obviously the world I sit in, you know, I think having that clear consensus around what is the best practice, what is the system that we're trying to build, can really help Medicaid policymakers think about how does Medicaid wrap around and support that capacity, that infrastructure of the system for the individuals who are covered, who are insured by Medicaid. So really appreciate the ongoing robust discussion around what does it look like to have the law enforcement system connected to, but not integrated with the crisis response system, and how do we move that forward? So appreciate the conversation today, the robust discussion, and I know this will continue to be a topic of focus for the crisis jam going forward. So with that, I will wrap us up and invite everybody to join us same time, same place next week.